Now, I'm pleased to introduce today's speaker. Dr. Pearl O'Rourke is the Director of Human Research Affairs at Partners Healthcare Systems in Boston, and she is an Associate Professor of Pediatrics at Harvard Medical School. She's responsible for the systems that support the regulatory and ethical oversight of human research and the responsible conduct of research. She's also the chair of the Partners Healthcare System Embryonic Stem Cell Research Oversight Committee. Dr. O'Rourke has worked as a pediatric critical care physician at the Children's Hospital of Boston, as well as the University of, as well as the Children's Hospital at the University of Washington, where she was the director of the Pediatric Intensive Care Unit. Following in 1995 to 1996, a Robert Wood Johnson Health Policy Fellowship for Senator Edward Kennedy, she became the Deputy Director of the Office of Science Policy in the Office of the Director at the NIH, where she worked on issues such as privacy, gene therapy, embryonic stem cells, and genetic discrimination. So thank you, Dr. Pearl O'Rourke, for joining us today.
So I'm sorry on that, too long. Today, the topic actually I was assigned, which I think is a great one given my understanding of your group, is what are topics in human subjects protection specific to neurology? And to start out, obviously the disclosure thing, I am a member of the Bioethics Advisory Committee of Takeda Pharmaceuticals. That's the only one I have to disclose. And I am not going to be talking about commercial products. So to start us off, I'd like to have you just in the back of your mind, and we'll come back to these three cases, but consider the following three cases. Study one, it's a phase 1 study of a promising new drug, or PND, for patients with advanced stage ALS. The protocol is a 6-week administration via a central line. Side effects, significant immune suppression, and marked decrease in platelet production. Okay, so bad disease, central line, and some significant adverse events. Study 2, phase 2 study of a different promising new drug for acute hemorrhagic stroke. The protocol requires infusion of the drug within 6 hours of symptoms. Side effects, extension of bleed, and severe allergic reaction. Clearly a different type of potential participant. And the third one, phase 3 study of yet another promising new drug for Duchenne's. The protocol for this is a 12-month course of twice-a-day oral meds. Side effects, bone marrow suppression, and severe allergic reaction. So, all three of these clearly require IRB review. So what I'm going to first do is go over just some of the basics of IRB review and the relevant regulations, and really come back and visit these three protocols and see what is particularly relevant to these three quite different studies. And before going into the basics, I'd also like to point out and make sure everyone realizes IRB review is prospective, and IRB cannot grant retrospective approval. And we occasionally will see this when someone comes and said, oh, you know, I did this pilot study, or I just reviewed a whole bunch of records and I'd like to get it published, but the journal wants IRB approval. We can't do it retrospectively. The second overlying uber point is the fact that only the IRB can approve a protocol. If the IRB does not approve a protocol, your vice president of research or institutional official or whatever leadership you have at your organization cannot override an IRB's disapproval. So the IRB is really key in human subjects protection. The IRB, which stands for Institutional Review Board, it's not Investigational Review Board, which oftentimes people do refer to that. It protects, obviously, the subjects who participate in research are the prime group that we're interested in, But it also protects you as investigators in that the rules and regulations are just too many and oftentimes too conflicting for someone who's just doing a few studies a year to really keep in order. So the IRB should really help you navigate the system. And it also protects the institution. And the IRB, you may think it's a committee that sits there and thinks, oh, what do I want to do today? They actually, the processes of the IRB are very tightly orchestrated by federal laws, but we also have to look at state laws. There are particularly around privacy issues, genetic issues, sexually transmitted diseases. So whatever state you're in, your IRB is going to have to be definitely aware of a number of different state laws. There's case law. If you think about Tuskegee, which happened actually way before the IRB rules were written, but that case clearly has had appropriately major ramifications in terms of how we oversee research. And if you do keep up with the literature on sort of bad things that have happened in human subjects research, there was Jesse Gelsinger, who in the mid 90s was an 18-year-old boy who died in a gene transfer protocol. And actually, what came out of the review of that is a lot of what we do today in terms of conflict of interest and also data and safety monitoring. If you have time at the end, I'd be happy to go into more detail for that. The IRB also has to be aware of who is giving the money for the protocol and what are the conditions that are part of receiving that money. Since a lot of research is funded by NIH, obviously NIH rules are very important. And before an institution can accept money on your behalf, your institution has to promise they're following all the conditions of grant award. And some make sense. It says, if you're using human subjects, you have to go to an IRB. You can't discriminate based on, age, sex, religion, race, etc. But a very interesting one in condition of grant award is your institution has to have a seatbelt policy. Use of seatbelts is good. What does it have to do with research and grant awards? I'm not sure, but I just throw that in there for the fact that your institution is actually looking at all these requirements. And for those of us here in Boston, the Boston Globe, if you see an article that comes out in the Boston Globe that is about a research disaster, remember that the IRB is a committee of your peers. They're reading the same things. And clearly, if there was a big study about a privacy breach in the Boston Globe or the New York Times or the LA Times, wherever you are, clearly, if you were an IRB member and read that, the next protocols you're reviewing, you're going to look in a lot more detail at what are the privacy and confidentiality protections. But anyway, so those are the influences that the IRB has to think about. And the only one I'm going to go down a little bit with you is the federal laws. And there are 3 federal laws that of which you should be aware. The Common Rule, which is called Common because 18 federal agencies have agreed to apply this to their human subjects research. There's FDA regulations, which are about 95% the same as the Common Rule, and HIPAA, or the Privacy Rule, which does have implications for research as well. And all of these rules or laws are constantly undergoing interpretation and new guidance from the federal agencies which oversee them. So what is being interpreted today may be different a year from now. And again, that's something the IRB will have to keep a finger on that pulse. I'm going to use the Common Rule as the example here. And again, remember, FDA is virtually, for most aspects of research, virtually the same. The Common Rule has 4 subparts. The first subpart defines research, defines what a human subject is, and it really gives you the recipe for how the IRB has to review the research. The other 3 subparts you can see here focus on vulnerable populations. And for each of these subparts B, C, and D, there are additional protections that you have to keep in mind if you're doing research on fetuses, prisoners, or children. And when you think about vulnerable subjects, you obviously could go, many of you can make a subpart E, D, E, F, and G. There has been some discussion about including a subpart on decisionally impaired, which I think would be particularly interesting for those of you in neurology. But so far, none of that has happened. As I said, the IRB, the common rule, as well as the FDA regs, define research and human subject. And basically, the way the law works is that the IRB has oversight of anything that falls in these two definitions. And the definition for research, and this is right out of the regulation, so it's a systematic investigation, including, as you see here, all aspects of the research. So a pilot study is research. But anyway, it's a systemic investigation designed to develop or contribute to generalizable knowledge. So with that definition, there are oftentimes questions that arise. Is it research or is it care? Is the individual who's receiving the article or the drug or the procedure a patient or a subject? And is the person who is providing it a clinician or researcher? So take an example. You're a neurologist. You have just read this new article that came out that presents a new way of treating Guillain-Barré syndrome. It's only been done in the article you read just reports 3 cases. You don't know anyone else is doing it, but basically they are purporting that this new approach will decrease the need for mechanical ventilation in severe cases. Okay, so that's the article you read. You then go to your office, and I come in, and I have Guillain-Barré. I'm admitted to the hospital, and I am having ascending of paralysis is going quite quickly, and actually, you're worried that I actually may end up on a ventilator. So you decide, looking at me, to try this new experimental therapy. Is it treatment or is it research? I should have put a little polling thing in here. I'm going to have you in your mind raise your hand. This would be treatment in that, yes, it's an experimental therapy, but you've made the decision based on me and my clinical course to treat me this way. So something like this would not have to come to the IRB. As opposed to, you're that same neurologist, you read this article, and you sit back and you say, too many of my patients end up on ventilators. What I'm going to do is, in our clinic, we're going to alternate between this new thing and a routine treatment for the next 6 Guillain-Barré patients. A new Guillain-Barré patient arrives, and you are going to randomly assign this new person to one group or the other. At this point, you're doing research because it's a systematic investigation, unlike making the decision based on what you think is the best clinical care. So in this second one, although you're doing the exact same experimental therapy, this would have to come to the IRB. This is a rather obvious case. Some of the others are not quite so obvious, and I would highly suggest that if you have any question at all, this really is a discussion you should have with your IRB. You shouldn't take this on alone. The other issue, the other very important definition that comes up is what is a human subject? And the definition in the common rule as well as FDA regs is a living individual about whom someone doing research gets data through an intervention or an interaction. This could be a phone call, a survey, a physical exam, a biopsy, any interaction. And a human subject is also just your identifiable information. So your medical record, your pathology slide with your identifiers on it is a human subject. So if you want to do a chart review looking at identifiable information, that is a human research protocol, and you need IRB approval for that. Okay, I'll leave that one there. Actually, no, I want to go back to that one. Sorry. The other point I wanted to make here is that in the common rule, the definition is a living individual. The common rule does not cover deceased people, but HIPAA does. Remember that HIPAA covers the institution that holds the identifiable information. And your personal information is covered by HIPAA until you are dead for 50 years. I I don't know why the 50 years, but that's what the regulation says. So you can see here, despite the fact the IRB has to think about these different federal laws, there's a disconnect here on some of the basic definitions. Obviously, you can't get consent from a dead person, so that's out there. The IRB has to do all of these things. The main focus from everyone is usually the initial review. And I know all of these reviews are both ethical and scientific. So next slide goes into a little bit more detail with that. The protocol has to be reviewed and approved before you enroll a first participant. It may be a full committee IRB review, or it could be expedited review. It can only be expedited review if the research presents no more than minimal risk. And for the sake of today's talk, I'm not going to go into great detail on what those things are, but they are defined by the regulations. This is not really up to your IRB. And some of them, to be honest, I think are a little too expansive. The types of studies we'll be talking about here today, these would all be full committee review. These are more than minimal risk. You're randomizing people, and there's interventions. Your protocol can only be approved for a certain period of time. Most protocols are approved for 1 year. If you are not receiving federal money for your research, your institution could decide to allow 2 years to go between continuing reviews, but that really is up to your institution. Your IRB can also say, we want you to come in more frequently. Let's say you're doing an extraordinarily high-risk protocol. Your IRB may say, we'd like you to come back after you enroll each participant. Or if, let's say, you're a researcher who's had some difficulties in the past staying in compliance, your IRB may say, we'd like to see you every 6 months. But the general rule is a year. Also, if you change your protocol at all, your protocol is not a general guide. It is a specific recipe of what you have proposed to do and what you should be doing. So if you change anything, such as you change study staff, you change, I'm going to give this antibiotic Q6 rather than Q8. I'm going to suspend this antibiotic in half normal saline versus 3/4 normal saline. Those have to come back to the IRB to be approved. Now, obviously, if something emergent happens, you need to do something for the safety of the participant, go ahead and do it and tell us afterwards. We also have to look at all adverse events, unanticipated problems, any deviations that you have for the protocol. And depending on the funding and the degree of problems or whatever with adverse events, there may be some reporting responsibilities to federal agencies. But those are the basics. And I think, again, initial review is the one that everybody focuses on. I just think important to be aware of the others. As I said, the review is scientific and ethical. And many IRBs oftentimes are questioned by investigators as to, why are you looking at my science? Well, basically, if it's not good science, it's not ethical. Regardless of the degree of risk in a study, if you're not going to get any answer out of it, even minimal risk is not appropriate. So your IRB will look at each of these. So what do we look for? Well, study design, and that's going to get into, is this something that's doable? If you see a study that says we're going to study hypertension in males between the age of 40 and 65, N equals 10. I mean, that's clearly, given that condition, that's not a reasonable study. So the design, the statistical design, very important. Data and safety monitoring has to be in place. This does not mean you have to have a board, but you just have to have a plan of who's going to look at the data and who is going to assess whether or not it is safe to continue. A touchstone of IRB review is looking at the risk-benefit analysis and making sure that the potential benefit makes the risk of the research reasonable. And you will be asked in your IRB submissions to, talk about what's the risk, what's the benefit, and, how do you justify. And that clearly changes as you talk about different patient populations. If you have a population who has an end-stage disease with no potential treatments, the higher risk may be, appropriate. In contrast, if you have a study on a new way of treating acne, any risk is likely going to be questioned. And then it's who's going to be included in the research and who's going to be excluded and why. Um, and you have to, you can't just say, oh, it's easier for me just to go get, let me take a different example. This study has high risk, so I'm just going to go and get participants from homeless shelters. Cannot do that. There really has to be justice in here. What is the study about? Who is the potential target population if anything good comes out of this? And your inclusion and exclusion criteria should reflect that. You will be asked if the targeted population is vulnerable, if it is a fetus, a child, or someone who is in jail. Added regulatory requirements will be required. And as an aside here, I would just mention that if you have a participant who actually is incarcerated, your IRB must review that, and your IRB must have a prisoner advocate as part of the IRB. And if not, they need to go to an IRB who does have a prisoner advocate before that participant can continue in the research. And the reason for this is that if you are incarcerated, it's awfully difficult to say, no, I don't want to do this research, which is likely coming at you in a positive way. So it's really protecting the person who's incarcerated. Even if you are not in one of those three categories that, that B, C, and D of the common rule covered, you will likely be asked for additional safeguards for a number of your participants, and mainly because of the concerns about decisionally impaired, as well as we'll talk about a minute here, the desperation of many of your potential participants. You'll also ask, how are you going to recruit people? How are you going to find them? Each institution has their own policies for this. Here in Boston, at the hospitals with which I'm associated, we do not allow cold calls. I think most institutions follow that rule. But institutions will have different rules regarding, can you email? If it's a letter, who has to send it? Should it be by someone that the person knows? And think about it yourself. If you were to get a letter in the mail saying, dear Joe Schmo, we heard that you have depression. Would you like to be in a study? Clearly, if that letter was signed by someone who you never heard of, the first question that should come to your mind is, how did this person know this? So oftentimes with many of these studies, having one of your care providers who knows that you have depression and introducing you to the person is more appropriate. So that is sort of how in the recruitment of participants. The other big issue is do not overpromise. Oh yeah, come on in. This is the best thing going for you. There's nothing else for you to think about. Please come into the study. Again, it is research. And definitely avoid coercion. We also look at privacy and confidentiality protections. It's how you're going to protect the data, as well as, let's say you're doing a physical exam or an interview. Where are you going to do that? You can't do that in a public space. So depending on your study, it may just be records retention and records security, but it may also be, where are you doing this? How are you calling people? And to make sure that, privacy and confidentiality are respected. The informed consent is both a process and a form. I think too much attention is put onto the form and not enough on the process. Excuse me, but the federal regulations do list specific things that have to be in your consent form, and your IRB will have that as part of their template. But to highlight just a few here, in terms of like the process, who is going to get consent? Who is going to not only invite this person into the research, but then actually sit down with that person and go over any questions? At our institution, we do have some requirements that the person getting the consent should be a person who can at least do the procedures that are proposed in the research, such as if you are doing a research protocol in which a brain biopsy is going to be done, we would expect a neurosurgeon to be part of the consent process. Your institutions may have different rules than that, but you should be aware of what it is. But the person If you were doing a very high-risk study, a study staff may not likely be the appropriate person to get the consent. It should be a clinician. Who will give consent? In most cases, it will be the participant. If the participant is decisionally impaired, how do you determine how decisionally impaired they are? There are a lot of people who are decisionally impaired in different aspects of their life, but who could give consent for research. So your IRB will ask you, what are you using to determine impairment? If they are impaired, who can give surrogate consent? This is highly driven by state laws. So it's hard to say, yes, this can always be the wife or can always be the sister. You really do need to look at your state laws. If it is a child, will there be an assent form as well as a parental permission form? This, in most situations, people start talking about assent forms anywhere from about age 6 or 8 up. And the assent is a shortened form, basically telling the child in an age-appropriate language what the research is about, the fact that it's voluntary, and again, if they have any questions. And if you're also doing research on the child, remember they are a vulnerable population, and there are some different risk analyses that need to be done. And I already kind of said to you, when and where will consent be requested? You want to make sure you have appropriate privacy, also appropriate timing. If a person has a chronic disease, they should be given time to think about the research, as opposed to thinking about 3 cases I put up front. If you're having a study on hemorrhagic shock or hemorrhagic stroke, clearly you can't think about that 3 weeks ahead. So again, your processes should reflect that. The regulations also allow, in certain situations, to waive consent. The waiver of consent, though, is virtually always when the risk is no more than minimal risk, or if it's just not practical to get consent. And again, in the studies I presented here, consent would never be waived. So let's go back to study 1. So this was the ALS study, phase 1, central line, and some pretty significant potential side effects. The first potential subject comes in. It's a 67-year-old white male who has a BS. He currently is in a wheelchair. He's beginning to have respiratory compromise. He lives with his daughter. He's been taken care of by the same neurologist for 2 years. His doctor is totally frustrated. After numerous phone calls, has finally gotten this patient an appointment with the best. And his doctor told his patient that if anyone can help you, it is this doctor. And, wow, this is not working well. And you are that doctor, okay? But you also, I'm sorry, one slide didn't come in here. The other thing I wanted you to know, I'm just going back to spring 5, not in here. What you also may be interested to know is that the patient's daughter has basically said, listen, things are going so bad, you got to do something, or else we're really talking a care situation. I can't take care of you at home anymore. So this person has a bad disease. He's been given this promise of this great new doctor who is you, and the home situation is fragile. So this is clearly a patient who's incredibly desperate. So desperate patients may have a disease with no therapy, only minimally effective therapy that's painful or has too many side effects to be reasonable. They can have financial desperation. They may be desperate to please you or their family members, not themselves. Too often, I think people do want to please their clinician. They want them to be happy. Desperate patients often have desperate families, such as the one we talked about here. They often have desperate doctors. And as you see this desperation, I just want to go back to what the informed consent and research needs to include. I think this quote from the BMJ now many years ago, but I think it's right on target. The informed consent really reflects the need for patients to fully understand that this is more than clinical care, that participation is voluntary. Alternatives may exist. This is not the only thing you can do. And the participant may not benefit, in fact, could be harmed. And when a person is desperate, it is very difficult to get all of these elements across. So the informed consent has to include benefits and risks. And very important, this is research. Your participation is voluntary. You do not have to do this. And if you do sign up and you decide to change your mind later, you can withdraw. Clearly, withdrawal from research, while it is something we have to guarantee the participants, I'm sure you can all think about research where it'd be impossible to withdraw. Think about an implantable device. Or for Parkinson's disease, if you're, talking about implanting stem cell created dopaminergic cells, obviously you can't withdraw, but the person, coming in with informed consent would clearly need to understand the limitation of changing his or her mind. Okay, so when you do go through the informed consent process and you have to talk about benefits, just a few things to just keep in the back of your mind. Everybody wants to say and everybody wants to hear that there's going to be a benefit. And clearly, anyone going to get informed consent, you want that person to say, yes, I would like to participate. And it's just human nature to try to say, there is a potential benefit. Painful to obviously say the different. The other one that is, if a potential participant says, well, what will this do for me? We commonly hear, well, no one ever knows, but there's always the possibility that you'll be the one to get better. Particularly when you're talking phase 1 studies, which really, are studies to see whether or not in most cases, drug, is safe enough to go on to a phase 2 study. It should not be promising therapeutic benefit. But again, people fall back on one never knows. And if you have a disease with no known therapies, it becomes much easier to fall into this. You may have many participants or subjects who already come to you knowing what the benefit is. They've read online, they have a friend who's in a similar study, and they have just heard all the positives, and I don't need to hear the consent form. I know this is the only thing for me to do. Sign me up. That really pulls you into the therapeutic misconception. It is research, yet many times people are thinking about it as therapy, and I think we all have a role in this misconception. It can be patient-initiated, where, again, this is bigger in desperate people, where something has got to be better than what is currently occurring. Think to years ago, they tried to do a bone marrow transplant study on women with breast cancer, and the study actually had to be majorly changed because too many people felt that, well, the current therapy is not all that great. Therefore, this new thing called bone marrow transplant must be better. Everybody wanted the bone marrow transplant, and many were unwilling to be randomized to routine care. The result of that study was that bone marrow transplant had no effect. And if you think about the downside of bone marrow transplant, huge. But again, people came in thinking they knew what was better. Physicians and researchers can also be responsible for therapeutic misconception. You're usually doing the research because you're hoping there is something else to do. Certainly there is comparative effectiveness research, which may have a little bit more equipoise, I think, in terms of I'm not sure which is better. But oftentimes with new therapies, the bias really is, I think this might be better. If you are both the clinician, provider, and the researcher, you're kind of in a schizophrenic situation. As the provider or the care provider, you should be offering to me as a patient what is best for me. As a researcher, you should be willing to say, I'm not sure, I'm willing to randomize. And again, if you are wearing both hats at the same time, this is a difficult situation. The recruitment strategy, we oftentimes, your IRB will have to look at any advertisements or any brochures you send out for recruitment. And it is always surprising to me how some of the studies will come in with, this is the best therapy you can get. And you want to go, no, this isn't. This is a phase 2 study of a new drug. you got to pull it back. So recruitment strategy is also part of this. There's also, I think, payers, I think, also get into this misconception. If there's reimbursement for research procedures, and is that not saying that this is clinical care? Again, that's sort of, I'm not a financial person, but I always found this intriguing. And then just remember that when there is no known therapy or limited therapy, virtually every clinical decision you make is experimental. It's hard to then not look at a new study and totally think of it as research versus clinical care. We also give a lot of mixed messages. Is it research or is this cutting edge medical care? Think back to my example of the Guillain-Barré. What if in the same hospital you have one person or one clinic who's actually giving the new Guillain-Barré treatment, whereas maybe across the street in a sister hospital is only done as research? I think as subspecialties, we are not always clear as to what we are purporting is research versus this is extraordinary medical care. There are also terms called therapeutic and non-therapeutic research. And again, therapeutic research would certainly suggest that this is clinical care. And this really falls in primarily with a lot of cancer studies. And the question does get raised, a lot of people will think a phase 2 cancer study is therapeutic. How about a phase 1? A phase 1 cancer study is different than other phase 1 studies. I don't have the answers for this, but you will definitely see these terms around. And then when we say to people, well, why didn't they realize this was research and this wasn't care? Again, you can see why perhaps people fall into this. I already talked about the reimbursement. The other issue is participants get confused as to, is this research, is this care? If they see a doctor asking for the consent form, looks like a doctor, must be a doctor, must be care. And the other thing to remember is the participants, as a rule, have very poor memories for what they signed up for. A lot of that is, I think, our consent forms are oftentimes not very good. The process may not be good. And people just remember what it is they're getting as opposed to all of the elements of the consent form. And I think if you're coming into the hospital with a chronic or an acute disease, it's going to require a lot of clinical decision making. And then you kind of intersperse in there some research questions. It can be very difficult for an individual to keep that all straight, particularly the same person or a same looking person explained and got consent for all of them. Again, that says the same thing. Okay. So presenting risk. I already alluded to the fact that the risk itself, as well as how people hear about risk, really depends on, where you're starting from. But who is the source of the information? If it's my mother-in-law, or is it, 900 of the smartest neurologists in the country agree on this risk? Very different. The nature of the risk, are we talking a rash? Are we talking bone marrow suppression? Are we talking death? The sensitivity will be different. If the risk is of high consequence, again, you might lose a leg, quite different than you'll have a rash. If everyone who takes this, if you're going to be in the study, you just have to accept that you're going to have a rash and a high fever. It's inescapable. So that's where you got to accept that before, there's enough benefit for me knowing this is going to happen. It's very difficult when you have a brand new procedure or drug that you're looking at, you really don't know what all the risks are going to be. And I have to say to some, right now, this is the best we know. We'll let you know if new information comes out. And in some studies that go over some period of time, as more is learned about the drug or the process or the device, you may have to go back to participants and say, when you signed up, we said that, there was no liver toxicity to this. Well, now we found out there is. So again, that can be confusing to participants. As you present risk, the best I can say is realize people are going to hear about risk from a lot of sources. You as the investigator will be one source and hopefully seen as the best source, but patients and participants are going to talk to their other health professionals. They're going to have a lot of unofficial experts, many of these on the internet. They listen to the news. They may be those who just say, oh yeah, I believe anything new must be better. So in presenting the risk, it's really as much as you can develop trust. Easier if you know the person long term, but really avoid overpromising. If you are presenting risk, realize that certainly our society does have a problem with numeracy in terms of really understanding what numbers mean. So oftentimes, graphs or comparisons work much better. I'm going to ignore that one for a moment. And we already talked, I think, ad nauseum for you poor guys, the extension of usual care. For the desperate patient, I already said they're already convinced that there's a benefit. They may not want to hear about the risks, but you have to go through them. If they see no other options, they don't want to hear about it. And many are pushed into this battle metaphor. We're fighting your cancer, we're fighting your ALS. And it's interesting, some patients have come back and said they hate that metaphor because they fear if they say, no, I don't want to do this, they're seen as a quitter. And will their clinician also quit on them? So it's a double, edged sword here. Some love it, some don't love it. I just put it here to be aware of it. So your options in the desperate patient, the ALS patient, provide additional protections. Just be aware of these issues. Spend more time really going on. This is voluntary. What are alternatives? What are the risks of this? Okay, may need more time for that. You may need more training. The clinician who's seeing the person may need to be pulled in so that they don't kind of give misinformation back. And everybody here needs training. Or you could avoid all desperate patients, which I'm not suggesting, or refer them elsewhere. Again, these two options are very tongue-in-cheek. So don't worry, I'm not going to spend that much time on the last two, and we'll have time for some questions. But let's go to study 2. It's a phase 2 study for acute hemorrhagic stroke. You have a 6-hour window. Side effects are also significant here. Your first patient comes in with meets criteria. Patient is comatose. What do you do? First of all, a study of hemorrhagic stroke. Plan ahead. This should not be a surprise when the first participant comes in. So definitely plan ahead. Know your institutional policies, which I already talked to you a bit about. And identify who can give surrogate consent and how can they give surrogate consent. Do they have to be there in person? Will you be calling the wife on the phone? If the person comes in by ambulance with no family members, does that mean that you can't enroll that participant in the study? Or does your IRB allow you to do this by phone? So think ahead of all the possible ways that this may happen. And again, I cannot overstate the need of looking at state and local laws. If you are getting surrogate consent, and if the clinical situation is one in which the competency of that person may return, such as in hemorrhagic stroke, maybe unlike an Alzheimer's patient, the regulations require that once that person regains their competence, they then have to be approached and say, do you want to continue to be in this study? Now, the example I gave of the acute hemorrhagic stroke, if all you did was one infusion within the first 6 hours, clearly they can't say, 2 days later, I don't want to be in that study. But again, if it's a study of longer duration, there might be long-term follow-up. The participant, once if they regain competence, has the right to withdraw. So again, that's a key thing. The third study, which is the muscular dystrophy, it's a phase 3 study, much more likely to get confused with therapy, if not seen as therapy. This one's a year-long study. We talked about the side effects. Your first potential participant is a 12-year-old boy who is in a wheelchair. A very active family and muscular dystrophy advocacy. And before they hear the rest of the explanation of the study, they say, we just read about this. FDA approved this muscular dystrophy drug. And here you see patients and families who are at the FDA hearings. And I'm assuming that most of you being in neurology have heard about this, but this created a huge controversy where there were members of the FDA who felt this drug should not have been approved, and that the approval was really somewhat, if not too much, influenced by the advocacy groups. And these are just some of the quotes I'm giving you here. By allowing the marketing of an ineffective drug, essentially a scientifically elegant placebo, thousands of patients and their families will be given false hope in exchange for hardship and risk. Another one that would send the signal that political pressure and even intimidation, not science, to guide FDA decisions. A standard this low would undercut FDA's ability to ensure that drugs are approved. While the focus of this discussion has really been on the FDA and the approval process, I think it also comes back to studies. And I must admit, we have not seen much of this yet at the IRB level, but I think the empowerment of participant groups, and in many ways, very reasonable and very rational, I think are going to become a very important part of how studies are designed and also how they're overseen. So in this one, we really hadn't, let's say you hadn't thought about this. The parents demand the drug as therapy. First of all, this may not be the same drug as was the one in the articles that you read. Parents may say, well, if you won't let me have the drug, I have a strong advocacy group, I can crowdsource, and I can do this experiment without you. And we are seeing some of this, where it's under the rubric of citizen science, which is a very broad scope of activities. But one little component of citizen science is saying that, okay, I don't need IRB review, I don't need you guys. If I can get my hands on X, Y, or Z drug, I can crowdsource through the internet and we can have our own study and our own design. I think that's an extreme example. I think you do need to understand that that is out there. And I think what this really emphasizes is the need to know the study population that is relevant to your study. There is, I think, very appropriately much more emphasis on partnering with patients early on, and really getting them involved in as consultants, as there's a number of different roles they can have, but get them behind the studies. Why is this important to your group? Why is it important to do the study, etc.? But I think at the point of this, if this were your patient or a potential participant who came in and you hadn't, this is the study, I think with these kinds of questions, this would not be someone who you would enroll in the study. I just think there is, that person were to be randomized. I think there's no way that that would be acceptable to them. Anyway, but I just want you to realize that is happening. So this is my last slide, I promise. So, in conclusion, I think many of the types of patients that you may ask to participate in research are in desperate situations. There is obviously a spectrum of desperation. Both, I think, the ALS is probably one of the most hideous. But even someone who has a tremor, you're desperate to get rid of that. And just realize that. I think you as neurologists will see a larger group of desperate patients than many others. I think research with these patients is critical. Recognize that they're vulnerable, and recognize that both your protocol development as well as your conduct of your research may require some additional safeguards and processes to best approach these participants. So I will leave it there, and I'm happy to take questions. I cannot see the question box, so I'll have to have Sam read me if there are any questions. So thanks for your time.